And next one is our another rising star, Dr. Sobia Laique. She's at Cleveland Clinic and has been very influential in taking over their Aasld program and obesity. Have some very interesting investigator-initiated studies that's been going on, and she will be presenting on updates on Aasld. So please welcome Dr. Sobia Laique.
Good morning, everyone. I apologize, I'm just trying to share my screen appropriately. Right. Good morning, everyone. Assalamu alaikum. Thank you, Dr. Hamid, for giving us the opportunity to present today. So what we're really going to be talking about now is metabolic dysfunction associated steatotic liver disease. And really, as we kind of review some of these high-yield abstracts, we're going to try to go through a theme really kind of initially focusing on where we stand from a natural history standpoint, some of the diagnostic challenges we're still having in terms of identifying high-risk patients, and kind of where we're heading in the therapeutic pipeline for fibrotic MASH patients, and then eventually some of the nuances of navigating care for patients, particularly with MASH-related cirrhosis. So with that, the first abstract that I really wanted to kind of highlight was a natural history study looking really at the evolving changes in terms of the comorbidity burden that we see in steatotic liver disease. So historically, what we've seen is predominantly that cardiovascular disease has been the leading cause of morbidity and mortality in these patients. However, with the increasing realization of cardiovascular disease as the leading etiology of death in the United States and the increased awareness and screening for it, what we're now seeing from this US National Vital Statistics data from 2010 to 2024 is that MASL-related mortality has tripled from 1.01 to 3.12 per 100,000 years of patients. However, cardiovascular disease has predominantly declined, and what we've really seen is a rise in obesity-related malignancy in these patients. Whether that's predominantly driven by hepatocellular carcinoma or metabolic-related other malignancies in the GI tract or gynecological, they didn't really parse out those details specifically, but that's a very interesting trend and really kind of emphasizes the fact that we should be doing a better job in terms of cancer screening in these patients. Next, we're going to talk a little bit about kind of the diagnostic dilemmas that we face when we're trying to identify high-risk patients. So this abstract titled Enhancing Steatotic Liver Disease Detection via Opportunistic Screening really focuses on using everyday diagnostic modalities that we have, for example, routine CAT scans that we might get for various different indications, and using those as an opportunity to see if we can maybe case identify MASLD patients better. And so what the group from Stanford really did was that they evaluated whether deep learning could enhance recognition of steatotic liver disease using routine CAT scans. So they retrospectively analyzed over 1,800 contrast-enhanced CTs that they had in their system using an AI tool called Comp2Comp. And what the algorithm really was able to detect was that upwards of 28% of scans that were done for patients identified patients with steatotic liver disease, which was significantly higher that was actually reported by radiologists, which was at around 12%, and significantly higher than what was picked up by ICD coding. ICD coding is a form of diagnostic coding that is pretty common in the United States in diagnosing or labeling patients with a certain diagnosis in their electronic health record system. And so really the clinical takeaway from this is that if we're able to, validate this in a systematic manner, it could really become a very good system whereby we have automated risk alerts within our electronic medical record system, improving awareness at a significantly larger scale. Next, this abstract really kind of caught my eye because it really speaks about how we can optimize current screening modalities that we have, particularly in the way of vibration-controlled transient elastography, and optimize that to better improve our rates of identifying at-risk MASH patients, which is particularly patients with MASH with stage 2 or stage 3 fibrosis, which are the patients who we want to identify to link to therapy. And so what this group from China really looked at was using radiomics within vibration-controlled transient elastography for non-invasive enhancement of hepatic fibrosis in MASH. So they took about 163 biopsy-proven Aasld patients and analyzed that group and specifically applied radiomics to the extracted vibration-controlled transient elastographies that they had. And then they linked that with certain clinical parameters as well. And so they ended up developing this model that they call the ARLA model, which used the patient's AST, their radiomics R-score, liver stiffness measurement, and then their age. And the model ended up performing pretty well with a AU-ROC of about 0.86 to 0.87, which is within the good to excellent category, and significantly outperforming a lot of the current non-invasive tests that we have in our current guidelines, whether that be the FAST score, FIB-4, NAFL fibrosis score, Aasld 3+, or Aasld 4. And the other thing to note is that they actually then did a sequential approach. So what's really kind of recommended in a lot of the guidelines from Aasld, Aasld, and some of the endocrine societies as well, is to kind of use this sequential approach of doing the FIB-4 score first, and then followed by VCTE liver stiffness to narrow down in identifying high-risk patients. And so when they did the FIB-4 followed by the ARLA, what they found was that they had a significantly reduced gray zone. So their classification rate of identifying these patients was significantly higher, performing way better than the other available NITs. And so really kind of just becomes a stronger tool in our armor to non-invasively identify patients as we move further and further away from liver biopsies. Next, we're going to move on to now a little bit into the therapeutic area. So in 2024 was kind of a landmark year within the MASH space because we had the first pharmacotherapy agent that got FDA approval in the United States for patients with non-cirrhotic MASH with stage 2 to stage 3 fibrosis. And so as this medication is now becoming more and more, inculcated into clinical practice, a critical question that then arises is how do you identify treatment responders versus non-responders? And what this really highlights is a really big challenge that we're facing as more and more MASH therapeutics become available, which is realizing that not every patient is going to respond to every pharmacotherapy agent, and how do you kind of almost devise this precision medicine model whereby you link the appropriate patient with the appropriate metabolic profile to the correct treatment strategy. And so what they really looked at in this real-world cohort study was looking at everyday available tools that we had to see if there was a mechanism through which we could early identify responders versus non-responders. And so what they saw was that using the vibration-controlled transient elastography CAP score, which is the steatosis assessment, and the FAST score, and an improvement in that, we even as soon as 3 months was indicative of a patient that was a likely responder to resmetirom. And then if you follow that along for another 6 months, then you saw the CAP score, FAST, and the ALT improve as well. And we know that the transaminases, particularly ALT, do tend to lag because resmetirom does, cause a mild transient elevation in transaminases in the first 8 to 12 months, which then starts subsiding. So really kind of a good mechanism to start getting some kind of early signals to see which patients will respond or may actually need to have treatment adjustments or switch to a different kind of treatment modality. So next, we're then going to talk about semaglutide, which was the second medication that received FDA approval just fairly recently, in fact, in October of 2025, to use for MASH with stage 2 and stage 3 fibrosis. And so as the Essence trial came out, one of the biggest questions that it kind of raised was, is the effect of semaglutide that we're seeing in terms of the histological improvement in MASH, whether that was MASH resolution or fibrosis improvement, was this largely being mediated through weight loss? Or was there a medication or drug-specific effect independent of weight loss as well that was allowing for disease improvement to happen? And so this was, in fact, a secondary analysis of the phase 3 Essence trial, where they tried to look at weight-dependent and weight-independent effects of semaglutide amongst the participants. So they took the 800 randomized patients from Essence, and they looked at the interaction between clinical outcomes. So, reduction in your transaminases, particularly your ALT, histological response, liver stiffness, and then correlated that to weight change. And what they did see that there was a significant weight-independent effect amongst all these parameters, which was independent of weight loss. However, in patients who did achieve, kind of the weight loss, you did see a higher rate of MASH resolution. So in patients who were hitting that 10% total body weight loss target, MASH resolution was higher from 48% to 72%, and fibrosis improvement also improved from 27 to 42%. And so really kind of the takeaway from this becomes that semaglutide does seem to work through a dual mechanism, both through its direct hepatic benefits and then the additional impact that it has in terms of improving the patient's cardiometabolic profile, just really kind of emphasizing its disease-modifying potential. All right, next we're going to switch gears a little bit towards now looking at patients with cirrhosis. And so really kind of the takeaway as we talk about this one is how do we determine if our patients with fibrotic MASH, what is their risk in terms of developing liver-related events, or what we call major adverse liver outcomes. So in this abstract titled Real-World Evidence of Liver Decompensation or Transplantation Events in Patients with Compensated MASH in the United States, they essentially did a descriptive analysis of 4 large US claims databases. And so these are national databases that are maintained between either the US government or pharmaceutical companies, namely MarketScan, HealthVerity, Optimum Clinical Informatics, Datamart, and IQVIA Pharmametrics databases. And they evaluated upwards of 140,000 patients between 2007 to 2022, really looking at the time to decompensation or liver transplantation. And what they saw was actually a cumulative 6-year incidence of decompensation or need for liver transplant was consistently being very high across all the data sets. And this was upwards of 24 to 27%, which is way higher than what's been reported in a lot of the clinical trials. And really kind of begs the question if, in a real world setting, compared to what we see in clinical trials, does the heterogeneity of the patients, the differences in the metabolic burden, and the differences in the healthcare that they receive, is that a better representation of the risk that these patients carry? And so the clinical takeaway for me as a practicing hepatologist really is realizing that my patients who are coming in with compensated MASH cirrhosis are a very high-risk phenotype, and that almost 1 in 4 patients that I'm taking care of are going to progress to either decompensating or needing a liver transplant within 6 years. And what this really then does is has, significant implications in terms of strategies that you implement for decompensation prophylaxis, how aggressive do we need to be with our surveillance strategies, and then how do we make assumptions regarding the natural history, not just for the clinical care that we need to provide, but also future trials that we may be designing for therapeutics, particularly targeting MASH cirrhosis patients. Next, I wanted to highlight another abstract, and this was a multi-center study out of Canada, and the abstract really kind of focuses on patients with Aasld that tend to actually decompensate at a lower hepatic venous pressure gradient threshold. And this was, to me, I think, a very striking abstract and something that, again, is very clinical practice changing, because what they did within this study is that they retrospectively evaluated about 409 patients and evaluated their hepatic venous pressure gradient thresholds for predicting decompensation and liver-related events in compensated advanced chronic liver disease patients. And they had about 1/3 of the patients with MASH. And so typically what they saw was that the traditional thresholds that we used for predicting decompensations actually very poorly performed in the MASH cohort. So the standard, clinically significant portal hypertension cutoff that we had of an HVPG of around 10 to 11 did really poorly in MASH patients in predicting decompensation, and that in fact, these patients were decompensating at a lower pressure gradient of around 6. And again, similarly, in terms of developing late decompensation, we were seeing it at a lower pressure gradient. And so again, this just begs the question, should we have individualized recommendations or guidance for MASH patients? Next, just changing gears a little bit, now kind of focusing on potentially what are some of the therapeutic targets that we have then for patients who have established MASH cirrhosis, who might in fact be developing clinically significant portal hypertension. Like, what can we do for this patient group in preventing, liver-related events? And so this study focused on efruxifermin, which is one of the FGF21 drugs that are being developed for treatment of not just fibrotic MASH, but also MASH-related cirrhosis. And what they did was they did a secondary analysis of the Symmetry phase 2b trial. And they used routine non-invasive tests to assess the drug's mechanism in terms of its impact on clinically significant portal hypertension and hepatic decompensation risk. And the outcomes that they assessed were, one, the Baveno 7 criteria for clinically significant portal hypertension, and then secondarily, they looked at what proportion of patients achieved a 20% reduction in Aasld-4, again, another non-invasive predictor of liver-related events. And what they saw was a pretty impressive dose-dependent response. So in terms of improvement in clinically significant portal hypertension, in patients who received the 28 milligram dose had a reduction of clinically significant portal hypertension in almost 18% of patients, and 13% of patients in the group that got the 50 milligram dose, which was clinically significant, compared to 29% with placebo. And very similar results in, the Aasld-4 group too. And so the question becomes really kind of what is our takeaway? And I think our takeaway really from this is that we have very encouraging results from the Symmetry trial in terms of the histological fibrosis improvement when efruxifermin was given to MASH cirrhosis patients. But again, this study also just highlights its disease-modifying potential in terms of even taking patients who've already developed clinically significant portal hypertension and reducing their decompensating risk. So, right. And then this is in fact, now the last abstract that I wanted to speak to. And this abstract really kind of looked at the risk of first acute variceal bleed in mast cell decompensated advanced chronic liver disease patients who were in fact receiving carvedilol-based primary prophylaxis already. And so what they did is that they took patients who had decompensated cirrhosis, so these are your Child-Pugh B and C, who already had had a prior variceal bleed and had evidence of high risk, or high risk stigmata of varices, who'd been initiated. They actually had two groups, one who previously decompensated and the other group that had high risk varices, who was placed on carvedilol for primary prophylaxis. And the significant finding from this abstract was that the patients, particularly the group that had MASH cirrhosis, had a significantly higher rate of developing an acute variceal bleed despite receiving carvedilol as primary prophylaxis compared to patients who had viral liver diseases. And so their hypothesis really was that in patients with MASH, there is such a profound insulin resistance and altered splanchnic vasoregulation that it almost blunts the hemodynamic response that we would expect to get from non-selective beta blockers. And so the clinical takeaway from this then becomes, are our current portal hypertension prophylaxis strategies not as effective for MASH cirrhosis patients as they may be for, say, viral etiologies or alcohol-related? And so do we need more personalized approaches, or do we need to consider earlier consideration of alternate therapies? For example, consideration for TIPS in a patient who's coming in with repeated large varices that we're not able to endoscopically manage. And that is all I have, everyone. I just wanted to give a shout out and thank you to all the investigators, collaborators, and clinical teams who are advancing, the care of MASLD and MASH, and all the investigators who submitted these high-yield abstracts for AASLD for us to review.
Excellent presentation, Sobia. It's hard to cover all the MASLD topic in such a short period of time. I think is there any question from the audience? I have one to start with. The last abstract, Sobia, you presented, it was also very interesting, and I was also thinking about our practice because we were using carvedilol, and then the thought with the Pavino that you don't need to have a repeat endoscopy for primary prophylaxis, but I have seen patients coming in. So have you changed your practice about, like, for primary prophylaxis, are you doing endoscopies on those patients and consider for pan ligation in this selected? I know it just came up, or is there any change in your practice based on that?
No, that's a great question, and I think really what Baveno did for a lot of people is give them almost, I would say, an air of caution that, if you have a patient who has a certain liver stiffness and platelet threshold, we don't even need to do a screening endoscopy. And I think seeing the data around MASH cirrhosis patients, one, decompensating at lower HVPG thresholds, and that they are unlikely to also be non-responders to carvedilol, I think in patients, particularly who have, and I think, I'll be fair, I think I've individualized it quite a bit. So in patients where I feel like their cardiometabolic disease is very uncontrolled, so that may be someone who has ongoing class 3 obesity, is an insulin-dependent diabetic. I will have a much lower threshold to scope, band, and if not responding, consider for TIPS. But I think, in someone who's lean, cardiometabolically controlled, you'd almost think that the insulin resistance component's almost controlled, which is driving a lot of this, that you may not need to be as aggressive. And then there's also nuances in them being able to tolerate the carvedilol because they're typically on other antihypertensives as well. So I'd say it's a pretty, individualized approach.
Perfect, thank you.
But definitely, not just sticking to the Baveno anymore.
Okay, I think we have few questions, Dr. Amjad Salamat.
Yeah, so just a quick question. Did this surmise on the reason for low pressure decompensation in these patients? What's the other factors leading to this sort of a thing? And is there a correlation between, you mentioned about Baveno 7, so is there a correlation between elastography and picking up these patients earlier for whatever we want to do?
That's That's such an interesting question. And I'll be honest, I'm very curious to see when the manuscript comes out because they didn't give those details. Um, I, I think as far as liver stiffness measurement is concerned, again, I think there's a lot of emerging data coming, a lot of that's actually going to be presented at, submitted to Aasld regarding the poor diagnostic performance of VCTE-based LSM in predicting, in using Boveno-based thresholds in MASH patients. So traditionally, we'll say, okay, well, if a patient has a liver stiffness of greater than 25, they have a high risk of decompensation. But what we're realizing is that the LSM in a MASH cirrhosis patient is often inflated because of hepatic steatosis, abdominal adiposity. And so that LSM of 25, 30 may actually not be truly reflective of a high-risk HVPG threshold. So I think as more data emerges, and there's a couple of different, scores that have recently come out. I think one is the Anticipate MASH score, and that paper was just published, I believe, in Gastroenterology, where they're realizing that for MASH patients specifically, we may need to have etiology-specific thresholds, taking into account their metabolic heterogeneity that impacts NITs.
Okay.
So,
Go ahead.
one more question. So this is regarding the liver fibroscan, the post-liver transplant setting, like in the de novo MASH. Is there any different cutoff or different CAP score, different fibrosis score? Because we are seeing a lot of post-transplant patient now with the MASH, with the de novo MASH. So the CAP score and the fibrosis score, they are different or they are like the same?
I mean, I'm going to admit that that's actually one of my areas of research right now. And I think recurrent and de novo MASH is so interesting. And it's, I think a lot of different centers have tried to use FibroScan or vibration controlled transient elastography to, accurately predict onset and then progression, whether that be recurrent or de novo MASH. And what you pretty quickly realize is how limited FibroScan is in terms of its performance, right? And so if you have, and I think from a CAP score perspective, you might get decent values, but the liver stiffness is often going to be often going to be inflated. And so we've seen pretty poor correlation between the measurements that we get from a FibroScan versus what we will get when we actually assess histology or do a liver biopsy. And so what you have to really keep in mind is that post-surgical anatomy where these patients have developed, either ischemic cholangiopathy-related biliary strictures, or they've had hepatic artery thrombosis and various interventions, all of that will impact the stiffness measurement that you get. So I think it's a good screening tool in identifying patients who might have developed recurrent or de novo MASLD, but it unequivocally needs a tertiary modality, whether that be MR elastography or histology right now, to definitively diagnose and then also stage. Because the correlation between the NIT and histology is extremely poor.
Okay, 2 more questions. I think Zishan and Dr. Khayatul Nabi Tabiyat, yeah.
One comment about the recent question of the transient elastography, because in transient elastography, we generally don't see the anatomy of the grayscale image of the liver, but the shear wave elastography may show a better results when we are looking into these altered anatomy patients. So that is again food for thought for those who are working in this area for post-transplant patients. The question regarding the beta blockers as a primary prophylaxis in this, most of these MASLD patients are generally metabolic dysfunction and diabetic and hypertensive. So it would be interesting to look into the dosage they have used and their blood pressure controls as well, because they have got systemic hypertension as well, and these patients generally are multiple antihypertensive as well. So that may be the factor which may have contributed failure of beta blocker prophylaxis in these patients.
Excellent. Thank you. Dr. Aasld Naviteya.
Dr. Sobia, excellent selection of the abstracts.
Regarding two papers, two abstracts that you have selected, one with the HVPG and its correlation with the early decompensation, and then the other paper where people tend to bleed even when there's an effective dose of carvedilol. They appear to be a bit contradictory to each other, because we also have the impression that people who are suffering from MASH, they tend to have varices early, and they tend to have varices of high grade, and most of the time gastric varices, and they tend to bleed and bleed heavily. Is it either because of apoptosis and leading to early decompensation and nothing to do with the fibrosis? Is it because of that? And when we come down to the beta blocker, in most of the cases, we are managing the cases quite aggressively with antilipids and ARB along with. I don't seem to have a problem with a combination of this ARB, beta blocker, and antilipid, and an extra risk of bleed. Bit of a challenge in that. Thank you.
Oh, thank you for your question. I think that there's just so many nuances to what you're saying, right? I think, again, this is preliminary data, and I think it's very important to wait for manuscripts to come out and then for these things to be externally validated. And so I kind of look at it as when these abstracts come through, what we're getting is a clinical signal. And so the question then becomes, is this gonna apply to a larger population? And then you kind of get into the mechanistic study. So I'd be very curious to look at this data myself. Now, in regards to patients bleeding when they're despite being placed on carvedilol, I think, again, you kind of have to look at the patient population we're looking at. And I think one of the things you quickly realize is that not all MASH patients behave the same. An individual that has class 3 obesity, is an insulin-dependent diabetic, has uncontrolled triglycerides, will have a significantly different cardiometabolic milieu and insulin resistance and impact on splanchnic vasodilation, as opposed to someone who might just be, from a South Asian background, who predominantly has abdominal adiposity and is maybe pre-diabetic. So I think this is an area where maybe we do need to get a little bit granular and look at really the impact of the metabolic comorbidities and how they're driving decompensation risk. Because what we do know definitively is that when we do get control of that, whether that is through metabolic or bariatric surgery, or whether that's through these incretins that we have coming in, between semaglutide and tirzepatide, which is when you definitively address the patient's diabetes and obesity, decompensation risk significantly drops. And so the question is, does that carry a significantly higher weight than the benefit that you might get from putting a patient on carvedilol?
Thank you so
I
much,
think that
Sobia, for an excellent presentation. Give a please round of applause to Sobia.